In this PowerPoint, we're going to talk about head, neck, and spine protocols. I don't think anybody's surprised by now, but VoiceThread messed up my text there. With this, I do want to preface by saying that we are not in a procedures course. So we are going to hit the bare minimum on the next few PowerPoints about anatomy and the protocols associated with it because we need a certain amount of information for this course to count as your education for ARRT. So if you're looking to take your CT boards, this would be the only class that you would have to take. It would meet all the requirements. If you are interested, you can still take your CT procedures course, but we will have some of the basics in here as well. So here are some common head imaging that we do in CT. We can do a head without contrast or a head with contrast. So the W/O means without and W/ means with. We do them for different purposes. Without can be more of just like a general survey of the brain. A head with contrast, we can look at the arteries and the veins, or we can actually look at perfusion, which means that we'll watch as the contrast passes from the artery and actually into the physical tissue. We also can identify if there is any abnormalities in the arteries or veins or tumors. Other things we can look at would be our orbits, which are our eyes and like the structures that make up the eyes, facial bones, sinuses, and temporal bones. For a CT head without contrast, some indications, which just means reasons that we're doing the exam. If somebody has reoccurring headaches or severe migraines, if they're sensing like vertigo, which means when you're not moving, you feel like you're falling. Somebody has seizures, and then it could be our first imaging for a stroke. We have to identify first if there's any kind of hemorrhage, because if there is, we don't want to just be immediately adding contrast. That's just adding fuel to the fire. Our scan type with these exams will be axial. So instead of doing our helical, more like a slinky exam, we do axial because the head will be in a head holder. And so we're not too worried about it moving, as unless it's obviously a patient that can't hold still due to seizures or something like that. But then we can use a strap over their forehead to help hold them still. And if they breathe, that should not be changing any kind of anatomy inside of the skull. So we typically are okay. Um, some sites, though, they just automatically have their CT machines always set to helical scans, and so you can see it done either way. Axial would be preferred because if you remember talking about axial scans, um, our images are going to be parallel and to each other and then perpendicular to the z-axis. They actually turn out better quality overall than our helical scans. And so sometimes we're looking at really itty bitty tiny things in the brain. And so some of those axial scans end up being better than a helical. But a lot of places, they have just set everything to helical and it's still diagnostic, so it's fine. Alignment wise, we say that they are going to be parallel to the SOML, or you can add a gantry tilt there. So you remember an X-ray, SOML is going to be the supraorbital meatal line. So we're looking from above the eyes, so like that ridge right above your eye, to back to your basically your ear, the whole of your ear. When you look at that, you're going to draw an imaginary line and you want it to be perpendicular to the table. So you're trying to match it to the gantry. If your patient cannot tilt their head back, or perhaps you need to have them tilt it more down, you can actually tilt the gantry in some machines. Not all machines do this, but you can add, just a few degrees one way or the other, and your lasers inside the gantry will align to the supraorbital meatal line, and that will help you set everything up. We like to align it to the SOML or have a gantry tilt because when you do that, you actually avoid exposure to the lens of the eye. If you don't do that, a lot of times the patient's head is not in the correct position. And to get all of the bottom of the brain matter at the base of the skull, you will end up scanning part of the lens of the eye, which The lens of the eye can receive less radiation before we start to see things like cataracts being developed. So we try and avoid it as best we can, so we align things differently. Our algorithms that we use, so these are going to be our windows. How do we want to see our images? So the first thing is going to be in standard, which is also called soft tissue. So in this window, the soft tissues are going to stand out more. They're going to be more smooth. It's all going to look a little bit easier um, to read within the tissue of the anatomy. If you select bone, it is going to be opposite. The tissue is going to look pretty noisy and grainy, and then the bone is not going to be bright white. The bone, therefore, is going to have more shades of gray to it where you could identify a fracture. So, if we cared more about the um, tissue, so if we're worrying about a hemorrhage or an ischemic stroke, we will think about the standard or soft tissues. That's what's going to show up better on there. But if we are looking for a fracture, we would select the bone window because it is going to highlight and make the bone more presentable for us. When we scan the head, we will typically have to be careful about the posterior fossa where our temporal bones are, because that area of where the mastoid air cells and the petrous pyramids are, they're really thick and dense. And when we image there, a lot of times we'll see beam hardening artifact where we see a dark streak that runs across between the petrous pyramids. Um, and the reason this happens is because that very, very dense area is going to absorb a lot of the lower and medium energy photons. And then the only thing that's left when it gets to the center where the brain matter is going to be the very high energy. So then the high energy almost seems to burn out the soft tissue. And so we see this phenomenon that we call a Hounsfield bar or beam hardening artifact. We'll talk about that much more later on, but just kind of wanted to throw that out there. We do have some software that we can utilize to help prevent it from being too excessive, and it knows what to look for, so it can kind of blur it out. But here's an example of what a CT head without contrast would look like. This is going to be in a standard or soft tissue window. And the reason I know that is because the brain matter. You can see the folds of the brain. And then the bone is very, very, very bright white. So if there was a fracture in the skull, we would have a hard time seeing it here because it's just too bright. But if we selected bone window, it would kind of flip flop that. Everything would be more grainy. And then the bone would be more shades of gray, and we'd be able to see a fracture very easily. Okay, so here are a couple examples. When we have the patient lay down, their head will be in a head holder. Once we do this, we then can kind of position the head, have the patient tilt, or have the patient pull their head back. So with this patient, just what I'm seeing there, the SOML would be pretty close. I can't see the actual laser light for the up and down inside of the gantry. Um, in my opinion, they should be raising the table up a little bit further for this patient. They're kind of centered more anteriorly. But as far as aligning, we want to make sure that we have this SOML, so that's supraorbital meatal line, and we want it to be perpendicular to our table. With the scan region, when you get your scouts on the image, it's going to show your APs and your lats. Some places will make you do both scouts. Some places will only have you do a lateral, and that's okay. With the lateral, you can see everything you have to include. So this yellow box I have represents you have all of the forehead, you have the vertex of the skull, and then you have the back, and then you have the base of the skull. So where it attaches to your spine. And if you notice, this is where our eyes would be. So we're trying to avoid that. So with this patient, if you were to just go ahead and scan the way it is, when we would be taking our slices, they would be like this. So when I get to the eye, because you see, I have to get all of this at the bottom. So I would be coming all the way down here in order to get that slice. But if they could have had this patient tuck their chin, then we wouldn't have had to worry about the slices doing that. The only other option then is where the direction of this box is, so has that tilt to it. If we can tilt our gantry to match that angle, and your machine will automatically tell you if it can or can't, then that will again take away the radiation exposure to the lens of the eye, which is what we would prefer. So making sure you get all of that anatomy in there, their heads in the head holder correctly, and your lasers are aligned. That's kind of the basics for how to set up your CT head without contrast. A CT head with contrast is often done without contrast as well. So we'll do it without contrast, and then we will inject them. So with this, we have what are called pressure injectors. I didn't really talk about much of this at all in this class because I talk about it a lot in procedures. But basically, you're going to have a power injector where you will put contrast into a syringe, and it is attached to a machine that will then, you'll set the pressure on it, you'll set how much you want to be injected. You'll start an IV on a patient, or they may already have one, and then you'll connect your tubing to it. And then it is set up automatically. So once you tell the machine how much is in there, how fast you want to inject it, if you need any kind of delay before you inject it, it'll automatically go when you go to do your scan. So we can evaluate something like a tumor mass, or we can evaluate the arteries, the veins, and also perfusion. We obviously aren't going to do this right away for things like trauma, fractures, bleeding, an ischemic stroke, or a general survey because that's not necessary to start. And some of them, like the hemorrhagic strokes or the ischemic strokes or trauma, we don't know what's going on at all. And we don't want to add fuel to the fire by shooting contrast through very quickly into a unknown situation. With tumors, MRI is going to be the preferred imaging method. They utilize a different type of imaging. So they're going to use a magnet, they're going to be changing the pulses to the machine, aligning the atoms in a different direction to get certain images. Versus us, we use the x rays and are based on attenuation data. And so, with having the skull all the way around the outside, sometimes the brain matter doesn't always appear super pretty. So, MRI is going to be our preferred method for some of those things. But as far as emergency situations, if they're concerned about anything head related emergency wise, they're going to send them to us immediately. Especially strokes, they don't even typically stop in a room if they know for a fact that this patient is having a stroke. If they're showing all the signs out in the field, EMS is going to call in. They're going to give us their ETA, and as soon as they walk in the doors of the ER, they're going to cart them down to CT. And so you better be prepared to get them on the table, get their scan done, because a radiologist only has so much time in order to them for them to make a diagnosis. If they have a we call them ischemic strokes. That's going to be your most common, and you'll see this on the next slide. But with strokes, we only have so much time in order to give them a medicine to help break up a clot with an ischemic stroke. So that's very important that we get it done very quickly. Okay, so a subdural hematoma, this is what we think of as hemorrhage. So we are bleeding in the brain. Typically, it's going to be in the dural space. So one of the meningeal layers, there's going to be blood involved. Um, when we have this, we are very concerned for the patient because it can cause a lot of damage and it can continue to bleed and bleed and bleed. So in our imaging, when you first see an ischemic or a subdural hematoma, which is a hemorrhage, we will see this, if it's fresh, we'll see it as a brighter situation. So what you're seeing over here, these top two images are going to represent a hemorrhage, and they're both going to be over on the right-hand side. So you can see it here, and then you can see it here. Sorry, I kind of got out of the line there. But that brighter area around the skull is what we're looking for with a bleed, especially due to trauma. Sometimes it can be more, centralized in the brain, but we're really looking for that. Another thing that I can already kind of see on both of these is we're looking for a midline shift. So you should have a midline that runs down your brain. And as you get additional blood inside that's pushing on the brain tissue, it can actually cause that midline to shift, and then it's putting pressure on the other side of your brain. And so that's something we definitely look for. And if we see a significant midline shift, it's not good for the patient. And so they're going to have to figure out how to get the bleeding stopped first off, and then also to help relieve some of the pressure by releasing some of that blood so it doesn't compress other parts of the brain. When you hear somebody say that they had a stroke, the most common type is going to be ischemic. So, what ischemic means is that there is a lack of blood flow to an area. When we see an ischemic stroke, it will appear darker if it's fresh. An older ischemic stroke can actually look a little bit brighter. But if it's literally happening right now or it's very fresh, it will be darker. Um, and basically, what that means is when you're losing blood flow to that area, you're actually seeing brain tissue die. So it's necrosing. And so we're really concerned about that. And you can see that here. So what's super important is they'll come to us first because as soon as we image and we can see the stroke, they only have so much time from the beginning of the symptoms to actually give the patient medicine to break up the blood clot. And sometimes it works and sometimes it doesn't. The farther out you are, you can't give this medicine anymore because it's no longer going to save the tissue. The tissue only has so long that it can survive without blood before everything starts completely dying off. So both of these are very important emergency situations that we are involved in. The next type of procedure that we're going to talk about is called a CTA of the head. So a CTA stands for CT angiography. So I'll write that out here for you. CT angiography. You also might hear them called an angiogram. With this, we are imaging the arteries in the brain, and typically we are looking more for the circle of Willis. So we'll watch as the contrast flows up into the brain, and then as it is filling the circle of Willis to see if there's any kind of abnormalities like an aneurysm or somebody has like a stricture in their brain. With this, the circle of Willis, we also refer to it as the cow. Um, we're going to see that over here on this image is going to be made up of multiple arteries. So we have our anterior cerebral, and then we're going to have our internal carotids on both sides, our middle cerebrals on both sides, and our posterior cerebrals on both sides. With that, if we see any kind of aneurysm or stenosis, we'll be able to identify that, and the radiologist can then make a diagnosis and determine what's next. A lot of times with patients that have strokes, we may introduce contrast to see where the stenosis is, to determine which artery itself needs to be opened if any kind of intervention needs done. For alignment purposes, we will use the same as a regular CT head. So we have to get all of the vertex, all of the front, all of the back inside of there, and we prefer to like tilt the head or angle our gantry if possible. For this, our algorithm is going to be standard only, so our soft tissues, because we do care about the contrast. And if we selected bone, it would be way too black and white, and way too grainy in certain areas that we don't want them to be. And so we definitely are going to be focusing more on the standard algorithms. For this to work with the CTA, obviously we have to introduce contrast. This is given by an IV, which the patient, if they're coming from the ER, likely already has an IV in place. You can just connect your tubing to, or you may have to start an IV if they're an outpatient. With this, you'll get very good at IVs. And I'm going to tell you right now, in the beginning, you're not going to be good at IVs. It's going to take you a while to get everything figured out. So, we can use different types of features where we can track the contrast as it goes up inside of the brain and make it very easy. So we can time it, we can track it, and see where it's located. If you want to break that down into a diagram, you can see the circle of Willis here on the brain. It's inside of this structure. And then if you wanted to pull it out again just to see just the arteries itself, it is right here. On this slide, this gives an example of something that we can utilize with our CT angiography. Post-processing allows us to change our imaging and make it look different. So we can do 3D reformations of our just anatomy in the brain itself. And so this is kind of a cool process because we put it into a different software on a separate computer from your CT monitor. And you will access the data and you will have to get rid of things that you do not want to see. And then you will highlight areas that you do want to see. So, for instance, in this, all we're seeing is the circle of Willis and then the arteries that bring the contrast and blood flow to the circle of Willis, which would be like right here. And so, this is going to be like a front view of it. And then we'll see the more of the collateral arteries, the smaller ones that branch off and go up into the actual tissue itself. On the right hand side, I do have it labeled in case you were wanting to kind of identify what we're truly looking at. Um, so we'll have like our posterior cerebral arteries right here. And then we're going to have our anterior cerebral arteries, the anterior communicating, our internal carotids are on either side here, as well as our middle cerebral come off of here. There's a lot that you can identify. So that's just something that we can do. The radiologist sometimes will ask for these. It helps them then pick out the exact vessel that has a stricture or an aneurysm, and you can see it in a different aspect. Another kind of exam we can do in CT is going to be CT of the orbits. And I wouldn't say this is done like extremely often, but it's done enough that we do need to talk about it. So some indications would be proptosis, which is where the eyes almost seem to bulge out of the eye sockets. If they have recurring pain in a certain location and they think they might have something lodged in there. So a lot of times we'll get like metal workers that have little slivers of metal or debris of other sorts in their eye. And then also if they have any kind of vision changes that are, they seem like consistent, like things are continuing to happen, they're not sure why. Um, Sometimes that can be brain related, all the way in your occipital lobe of your brain, or it can be dealt with in the orbits themselves. Alignment is going to be different than our normal head and CTAs because we are going to try and actually image the eye. We're not trying to avoid it now. So we have to tilt the head back a little bit. So we bring the chin out or up towards the ceiling, and we try and align our lasers so that we are parallel to the hard palate. The hard palate is actually going to be the hard portion of your upper portion of your mouth. So if you think like above your teeth, if you put your tongue on the roof of your mouth, the kind of anterior and then the middle portion is going to be your hard palate. So we're trying to align basically to this line. So this patient is not lined up correctly. However, we can tilt the gantry if necessary to get everything aligned better. Um, Typically, we don't use any kind of contrast for these with trauma situations. So if they have something stuck in their eye, or if they're in a car accident, we're worried about what's going on with the pressure in the eye. We are not going to introduce IV contrast because that can alter the pressure and change the bleeding. If it's non-trauma, we could look at using IV contrast if they're more worried about the proptosis without worrying about the pressure, or if they are looking for abnormalities, like there could be a tumor on the optic nerve, things like that. So we can use IV contrast. Again, it's just given through the arm, and then we wait a certain amount of time before it would enter into the eye socket. Algorithms for this, typically we're going to be using soft tissue or the standard to look at the lens of the eye, the optic nerve, all of those soft tissues. If we're worried that they had trauma and we're worried about the eye socket, the bone that's surrounding it, where perhaps they were hit in the face and we're worried about a fracture, we will then use a bone algorithm. And I can't remember if I've mentioned this before, but just because you select one of these algorithms does not mean that you can't also have images in the other. and you don't have to rescan the patient. You would just save your soft tissue algorithm on one set of images, and then you can actually tell the machine to create your original images, but take them and put them into a bone algorithm. So then you can send both of those through, and you don't have to rescan the patient. So that could be helpful if somebody has been in an accident and we're worried both about soft tissue, like the lens of the eye, we're worried about the optic nerve because there might be a fragment of bone that's pressing on the optic nerve. So then we want to look at the fracture more in detail. So we can do both of them. So that it's never like a you have to choose one or the other. You can do more than one. So here are some images from orbits. So we do get both sides at once from an anterior kind of axial approach here. Remember, we're only going to be focusing on the field of view that's necessary. So it is cropped down, but you can see the eye here, the optic nerve running back, and then you can actually see the lens of the eye in here as well. We can also see the bone surrounding. If there was any kind of fracture, we'd be able to note that. From a sagittal view, we can see again the eye, bones surrounding, and then we can see the eye, the lens, the optic nerve, and actually how it passes through into the brain. And then all the way from the front, this is going to be a coronal view. We actually can look at the individual muscles that hold the eye and cause it to move. So there's going to be four, sometimes five that you can see really well, but you can typically see four around the outside. And then most of the time you can see the optic nerve running down the center of the eye socket. And then you can see the whole area where the eye would be. I don't like looking at coronals of orbits or facial bones because there usually is going to be a couple slices where it looks like a creepy monkey. And this is what I see here is kind of like a creepy monkey. Um, but it is a good view to look at the muscles and identify if there's any kind of fractures that are, protruding down into the space. If there's any kind of additional blood, there's a lot of good things for the coronal view. Facial bones are another area that we can scan with CT. Typically, with this, it usually involves a lot of situations with trauma, or if we're worried about some person having a mass on their face, or if there could be kind of some random swelling that there's no reason for that just will not go away. So, with this, again, we're going to have a different field of view. So, we will be scanning with the patient. We are wanting to image all the way out anteriorly on the face, and then we come back usually to about the ear, and we go all the way up to make sure that we include our frontal sinus. So we come up a little bit further than the top of this frontal sinus. So as you might notice, this patient's laying a little bit differently. So instead of laying flat on their back, this patient actually would be laying on their belly, and their head and their chin are extended out. So, a lot of times we do facial bones with our sinuses. So, if you include them both together, sinuses are better seen when the patient can show an air fluid level. So, when they are laying on their back, it's not as easy to see air rise and fluid sink. But instead, if we lay them on their belly and we bring their chin up and lay it on the table, um, it's better of a realistic expectation. So we're able to see it more like the patient is standing up in the air. One thing about that though is it can be very, very difficult to get the patient to extend their chin that far. So a lot of times we still end up imaging them with their back on the table. And it's okay, it's just not going to give us the best air fluid levels. If you're just doing facial bones, it doesn't really matter all that much, but a lot of times they want to look at both. For the alignment purposes, we do want to be parallel to our hard palate when the patient is going to be laying on their back. So that's very similar to um, how our patients are for our orbits, right? So we're going to set them up very similarly to that. If they are laying on their belly with their chin extended out, then we actually want to be perpendicular to the patient, their hard palate. So in this situation, here's their hard palate. And so we would want to be perpendicular to that. So our patient's pretty dang close to that. Our algorithms that we'll utilize if we're worried about masses or bleeding or swelling, we typically will use a standard or soft tissue algorithm that'll display that the best. If we're looking for fractures, though, we will be utilizing a bone algorithm. Contrast purposes could be for identifying, again, that swelling or mass. If a patient has like a very disgusting tooth abscess. And the reason I say disgusting is typically normal tooth infections are not sent to us. They would do like an x ray panogram. Um, but when it gets really, really bad to the point where it's like eating away a bone, it's a really deep infection. That's when we can see these abscesses start to grow, and you might need to look at it with contrast so you can see the extent of the abscess. So there's are a few things that we might use IV contrast for. So here's a couple examples. So this patient was laying on their back when they were imaged. And the reason that I know that is because in this sagittal image, remember our field of view is very different, but I can tell in this image that the air has floated to the top, and then the fluid in the sinus, this is the maxillary sinus, is all floated to the bottom. So, with that being said, we know that the patient has to be laying down. If they were laying on their belly with their head more upright, the fluid would gather at the bottom and then the air would be up top. We also have a coronal image over here. So with this patient, you can definitely see that they have a lot of fluid involved. One thing to point out is that you can see that there is a fracture of their orbital area. So right here, there's also a fracture over here. Depending on the situation, this could be a tripod fracture where the bottom of the orbital rim area is actually going to be broken, and some of the contents will spill out into the maxillary sinus. And so that might be what is occurring here. I don't have all the views or all the slices, so I can't 100% tell you that it is what it is. You can also see there's some issues on this side going into their nasal bone region. Their vomer bone is off to the side, so it looks like it is could be possibly broken, or they could just have a malformation. Again, I don't know all the patient's history, haven't seen all the slices, anything like that. But those are a couple images of what facial bones slash sinuses could look like. If we were looking at just sinuses, we can cone down a little bit more with our field of view because we don't need all of the facial bones to include like the nasal bone and the mandible. So we can cone down, make sure we have all the frontal sinus, we have all the maxillary sinus up in the front. We typically come back somewhat close to the ear and then up, back, and around. Reasons for a CT sinus could be inflammation of the sinuses, chronic inflammation, chronic like congestion in the nose, and if they get a lot of sinus infections, if they have pain in that area, and again, some type of trauma. Again, I mentioned before we prefer the patient to be laying on their belly, so that's prone, which is what this patient is set up as. You can really see the extension on this patient's neck down here at the bottom. However, if that is unattainable, then we could do them supine with their head back, and then we would want to be more parallel to that hard palate. Our algorithm typically with sinuses is going to be bone only. And the reason that we say bone only is because it is going to change the consistency of what we're looking at. It's going to make the fluid actually pop a little bit more. Because we are trying to identify if there's also a fracture in the area. Bone just really seems to work better for sinuses. We have so much bone in that area. And unless that there's a mass that we're concerned about, we typically will just use bone. Contrast, we don't need to introduce contrast because contrast is not going to go into the fluid like it would for other areas. Those sinuses should be black to begin with, and if there is fluid, obviously there's going to be some form of shade of gray. So we don't need contrast in order to see that due to the nature of what the anatomy is supposed to look like. Here we have some images of looking at the sinuses, It's hard to get all of your sinuses on the same slice. So when we're looking at things, we may only see a couple of them. For instance, here we can see what I'm assuming is either, I think it's our ethmoid. It would depend on the slice. I'd have to be able to slide through, but typically your frontal and your sphenoid are in a little bit lower or a different situation. Sphenoid's usually a little bit lower and posterior, and then your frontal sinus is more anterior and superior. But we have our maxillary sinuses on either side. And then we're going to see this is where our nose area would be. Obviously, we're not all the way out to our nose, but we can see the vomer bone in the center as well as our nasal conchae on either side. So that was a coronal image. And then now we have an axial image on to the right hand side. Again, now we can see our full nose here. Coming backwards, I believe this is going to be our ethmoid sinuses are pretty low there. And then we're going to be able to see our maxillary sinuses on each side as well. So again, like I mentioned, they should be black because there's nothing inside of them until we get fluid involved. And then we will start to see some shades of gray within those cavities. Here we are seeing our temporal bones, and occasionally we will do this. We're mainly focusing on pain in the area for an extended period of time, or if they're having hearing loss, they could also have like really bad ringing in their ears, and so we can evaluate that. With this, again, we are going to change our field of view. So we are trying to encompass all of our hearing components. And then we do quite a bit from front to back just to make sure that we get all of the anatomy that's necessary. Um, so sometimes we extend out a little bit further there. We also want to be parallel to the hard palate. So just like a few other ones, the patient will be laying on their back. And we are only going to choose bone because our temporal bones are very dense. That's the only way I can choose to describe them. They're very thick and dense. And so we don't have a whole lot of soft tissue that we're worried about. We're going to be looking more for like the mastoid air cells that fall in the temporal bone and the petrous pyramids. We want to evaluate all of that. So in order to see fractures and um, identify the tiny little bones in your ears, sometimes they're called crystals, that allow you to hear, like your incus and your stapes, we have to make sure that we identify them. And if you just use a standard window, that's going to make the bone way too bright and you're not going to be able to identify those individual structures. Over here, we can see now that we have an image. It's in the axial section, and we are identifying the temporal bone. So along this line here, we call this the petrous pyramid. Inside of there, we do have all of these little tiny um, black circles, ovals, random shapes. We call those our mastoid air cells. Um, Also inside of our ear, so if you can actually see the ear tissue and flap off to the side, that's coming up against the skull. We would actually be able to follow that all the way in. It's not a good image on this to see the ear canal. We'd be able to see it, and then we could see where the eardrum is, the incus, the stapes, the malleolus, or the malleus. I never say that right. And then here, though, is a really good example of internally, we can see the internal auditory canal. So through those different slices, we'd be able to identify all of those small bones, as well as is there anything going on? Do we have a mass in the area? Is there some type of compression on these, or there's a fracture? There's so many options we could look at. It's also important to point out that all of these are going to be very, very, very small imaging, so extremely small slices, because these crystals are extremely small. So we don't have a very big field of view, so we will take a lot more images in skinnier slices to see the things better. I've also included in here moving down into the neck because a lot of places they do head and neck imaging together. One thing it's a little bit less common is a soft tissue neck. So we can look at that as well as a neck with contrast. Typically, we don't just do the neck with contrast unless there's a interesting mass or swelling that we just can't identify. If it's a trauma or if we have a stroke or worried about the carotid arteries or the jugular vein, we are going to usually image those with the head as well because if the neck is injured or if an artery or a vein is giving them a problem, they just want to keep following it all the way up. So a lot of times we'll image from high chest all the way up into the brain. We also can image just the neck if we want to look at the C spine. So we'd usually start a little bit up in the skull and then we'd continue all the way down through T1. So we make sure we got all 7 vertebrae, and we can see all that information. So that soft tissue neck, like I mentioned, your patient, we're going to be looking for things like a neck mass abnormality, there's swelling going on. And so we are going to include the neck. We don't need to open up all the way front and back to include like the front of the face or the back of the shoulders. We just have to make sure we get the skin line coming up. A lot of times we'll come to the front. This is actually a little bit wider anteriorly than I probably would choose. Um, but if they're worried about like swallowing or things like that, then I would probably include all the way out through the mouth. Depends on the indication for the exam. But we come up, we make sure we get part of the bottom of the skull, and then we get down partially into the T spine. So we include everything that is necessary. With these patients, we usually just have them put their head in the head holder and we'll have them tuck their chin just slightly. We're not truly trying to align anything like facial wise. So that's nice. With the algorithms, if it's just the soft tissue, then we could just use that standard soft tissue window because that's all that matters to us at this point in time. Contrast could be required if we want to identify the mass or an abnormality that we're just not really sure what it is. And so we can give IV contrast through the arm and then wait for it to get into the neck area. Here's an example of what just a soft tissue neck would look like. Um, so we have us on the sagittal plane over here. So you can look at it from the side. You'd be able to see this is a patient's tongue. So their mouth would open here, and then they would swallow, and it would pass down through their esophagus. This patient's actually taking a breath at the moment, and so with that, they actually can see where the trachea would be. So you can look at all that. You can look at some of the spine and the spinal cord in there. In the axial plane, you can actually see like this vocal cords. This patient has had contrast, and I know that because I can see the carotid arteries and the jugular veins on there. But we can also look at the C spine. So there's a lot of imaging that we can look at for in the neck region. As I mentioned, CTAs in the neck region are also going to include the head. We often use these for post stroke patients. So we get them in, we do our head without contrast to get a survey and figure out what's going on. And then if there is a stroke happening, then the radiologist or the ER physician will let you know if they want a CTA. Um, it depends on their protocols for the hospital, but they may say, I want a head and neck CTA. So you would introduce contrast. You would set a tracking bolus in the aortic arch, which is going to be found, and I can show you a diagram on the next slide, but it's going to be found somewhere right here. So you'll put a little ROI dot in there for your tracking software. And once it hits a certain Hounsfield unit, it knows that it's bright enough, it has enough contrast in there that it'll start your scan. So it'll start imaging from bottom to top that we watch the contrast as it flows up through the carotid arteries. And it will get into the internal carotids and then into the circle of Willis. So we'll watch all of that as it happens. We could identify an aneurysm. We could look at a dissection, a stenosis of some sort. So all those things are important with angiography. Alignment, very similar to just a regular neck. We want to make sure that the patient is supine. We just try to make sure that their head is straight. You can kind of tuck the chin just a little bit. If you want to align like you would for a head, that's fine too. It's not going to make that big of a difference. Since we're using contrast, in order to see that contrast flow very well, we are going to use a standard algorithm. It's going to make those arteries very bright white, and so that's what our focus is. If we want to change things up, we could look at things in a different window, but typically we'll use that standard soft tissue window. So here's that example on the diagram. Your aortic arch is down here. We would place a bolus tracking software there. Once it hits that certain Hounsfield unit, we would then watch as it continues up into the brain. We would find the circle of Willis in here, and we would then decide, is there something going on from there. On the left is an example of just the typical imaging that we utilize with the axials in CTAs. So we are able to see it in an axial slice. This patient has contrast introduced because I'm able to see the carotid arteries and identify that they've already split. So one's going to go up into the brain, and then one's going to go up and feed the face with contrast. So we'll be able to follow that all the way up through every slice and see then as it goes into the brain. One thing that is cool that I mentioned is that we can do that 3D reformations with post processing. So it's really interesting because we get to choose how much anatomy we want to be visible. So, like over here, it's a special software. You can still see some of the bony structures. And you can actually see the patient have a portacath placed. You can see that on the chest right here. But we get to decide if we want to keep all these extra structures, or we can choose to basically delete it out and then only see the vessels. You can see the aortic arch here. You'll be able to watch as they extend off and go up into the carotid arteries, and then you're going to have the internal carotids that come up into your circle of Willis. So we can choose to do that. The 3D reformats are honestly really cool to work with. You do have to know your anatomy though, because it is up to you to choose what is present and what is not. If you accidentally select to cut off the middle cerebral, the internal carotids, any of those things that are important, then the radiologist is going to call you and say, where's my circle of Willis? Why did you send this through? And then you have to be honest that you did not know your anatomy. But you get really good at these once you start working with the software. At first, it's a little bit of a challenge, I would say, because if you've never done things like Photoshop or altering pictures, things like that, you may not have quite the eye and the knack for it, but it comes pretty quickly. You just have to do a handful, and then you're ready to go to continue to work on it. I personally enjoy working with these things, but I also do enjoy like messing with photos and Photoshop and things like that. So um, definitely an interesting part of CT that I don't think a lot of people know exists. CT venograms are not super common, especially in the brain. Sometimes we do what are called runoffs, and we'll watch the contrast run through the veins in the legs after we've done like a CTA. Um, Sometimes it looks for the arteries, sometimes it looks for the veins. Kind of just depends on your situation. But head venograms are not as common. We only have one indication, and that is to look for cerebral sinus thrombus. So, what happens is when your brain perfuses that blood, it has to go somewhere after it's done in the tissues. So, it collects in sinuses, not your like normal face sinuses where you get like mucus and blow out of your nose. Not that. You have sinuses in your brain that are going to collect that. Some of that fluid, and it's going to return it back to a different location. Typically, they're going to dump into the jugular veins, and then it's going to dump into your superior vena cava before going back to your heart. So, with that, we have to be careful that we're only doing it for a certain reason. So, we're looking at some type of um, clot or something that is stenosing this area that's preventing some of that from going back to your blood flow. Algorithms that we utilize, we only use a standard algorithm. I did accidentally leave in the numbers for this. I always go through all of that with procedures, but you don't need to memorize that because I will not test you on that in this course. But if you take procedures, you're going to understand what window widths and window levels we choose for different exams. We'll talk about window widths and window levels later on, but I'm not going to make you memorize something like this right now. IV contrast is important. We have to do it. If we don't have contrast, we can't see the blood flow. We can't see it go into the sinuses and then where it's stopping. So we will inject contrast. The only problem with this is when you inject into your arm, it's going to go through your vein back to your heart. So then we have to wait for the blood flow to pass through the heart the blood flow to pass through the arteries. And then we're waiting until it gets to the sinuses in the brain, and then for it to go try and go back into the jugular vein. So, with that being said, we have a major delay. We're waiting almost a couple minutes before we're going to scan the patient to do the venograms. Because if we scan too soon, we're not going to see the contrast in the sinuses. It takes a little bit for it to get that far into the body. And this one's different than other head and neck imaging. Instead of scanning it from inferior to superior to watch as it goes through the arteries, we are going to wait and we're going to scan above the head from superior to inferior. And the reason for that is because that is the direction of the blood flow. We're going to watch as the blood is going to be perfused into the brain. It's going to enter the sinuses and then it's going to exit the brain through our jugular veins. So, that being said, we have to scan superior to inferior. If you go the other way, you're going to be following the contrast in the wrong direction. Okay, so that is what we would see for a venogram. So we are going to watch, and some of your sinuses that we're particularly looking for are going to be back here. We want to be able to watch as a contrast. So these are all arteries still. But once they get into the brain, they're perfused. Then we're going to wait until it gets back into the sinuses. And so you're going to be able to tell this is the best option. But actually, you should see more of a collection of the contrast rather than it being kind of this awkward, weird shape. And typically, that's due to a thrombus of some sort blocking some of that flow. I also included spinal imaging in this PowerPoint because we kind of talked about being able to image C spine. But we can actually image C, T, and L spine. We can also do like sacrum coccyx. We can look at all of that. Typically, this is going to be due to an injury or severe pain for a long period of time. There could be like a compression fracture that they want to image. Or if they were in a car accident, we're looking at the spine. There's a lot of reasons. Another thing could be if we're looking at the spinal cord, seeing if there's any kind of compression there. And they may take that a step further and do something like a myelogram or an MRI with it. But a lot of times, if it's, we need to get something figured out, they'll start with us and then move on. The alignment is going to include all of the spine, like vertebrae within the region. But we also have to have overlap into the areas above and below. So we say one vertebrae above and one vertebrae below. So if I'm doing T spine, I would include C7 and I would include L1. So I'm getting one from above, one from below. If we're doing C spine, there's not a vertebrae above C spine, right? So I would say bottom of skull, and we're getting all the way down to T1. Another thing is we're going to do our best to remove our arms from the scan field of view. So if we're doing T spine, we try and raise the arms above the head. Same thing for L spine, just getting it out of the way. Sometimes you can just like have the patient cross them over their chest, and that'll be fine for L spine. I don't like to like chance it just in case their elbows get down into L1. If we're doing C spine, though, we have the patient bring just them down by their side. We can do a bone algorithm if we're worried about a fracture, or we can do a standard algorithm if we're more concerned about the soft tissue, the muscles, the spinal cord, things like that. So here's an example of C spine imaging on the left, and then we have actually a T spine on the right. So these are both going to be from a lateral perspective or a sagittal image. So from here, this is going to be looking at the spinal canal. You can see all of the vertebrae here. This is going to be like their vertebral bodies, and then these are all of the spinous process that exists for them. You also can see the as a patient is breathing here, so you can see the airflow in there. This part is just an x-ray that I wanted to put next to it so you could see from the lateral perspective. We have the vertebral bodies and then we have the spinous process sticking back here. So this is kind of the area that you would choose on your scout image that you take. I have an axial view over here. This patient, you can see we kind of cone down a little bit just to look at the T-spine. One thing I will say is I know for sure that this patient is going to have more of a bone detail on this side. And the reason I say that is because it's very speckled, so it's very a little bit more noisy. But if you look at the bone is not overly bright. We can see some bright areas to it around the outside, but the internal portion has a lot of shades of gray. So if there was a fracture inside that vertebral body or the spinous process, the lamina, transverse process, we would be able to identify those very easily. So um, definitely something that we look at pretty frequently. And something that's nice is we can actually take an entire chest CT and we can break it down and make a new field of view, um, which would be the display field of view. That's the only thing that you can change. And you can send through an entire new data set only looking at the spine. So you have all the chest information, you've already sent all that through, but you can go back and you can actually cone down to the spine if that's what they're wanting to see a little bit better. Here, we're going to have an L spine here. Again, this is going to be more of a lateral perspective, and we're looking at it from the sagittal view. You can see here that this patient has some form of probably degenerative disc disease, meaning that there's no longer a joint space and there's a lot of compression happening there. This vertebrae does not look good to me either, and this one is not looking so hot either. It's also looking like it's pulling forward. This one down here is another C spine, but we're looking at it from a coronal perspective. So you can actually see C1 off to the sides, and then you can see C2 with your dens process sticking up inside. Over here on the right hand side, we have kind of a combination of T and L spine. So we got a lot of the patient's body on here in this sagittal image. I do have it shown with like actually numbering out the vertebrae. And you could look at all of those things, determine, like I said, compression fracture, if there's something compressing the spine, any other type of fractures due to trauma. There's just a lot that you can look for in this area. One last thing that I included in here was a CT myelogram. So it's very similar to X-ray myelograms. However, we will be imaging them to look at the spinal canal in obviously 3 different planes. So we can have situations where the patient has radiculopathy, which means that they have a lot of tingling sensation and even kind of a numb sensation in their arms or legs. So we're worried about a compression on the spinal cord. Other problems could also be if they have a mass in the spinal canal region, if they have a subluxation of a vertebrae where one slips forward on the other. There's a lot of things we can identify with a myelogram. I will say, though, that our myelograms are becoming a little less frequent now that we have such amazing MRI. They can see things like that without having to use radiation exposure or actually injecting the way that they do. Our algorithm is going to be bone only. That's going to help highlight the contrast. What they do is they do an intrathecal injection. So intrathecal means you're introducing it to the subarachnoid space, which is in your spine. So it's kind of like an epidural. They're going to go down very low in your spine and they will insert a needle into that space and then they will inject contrast. Oftentimes, they actually do the injections in X-ray, so they can use fluoro for it. And then once they have it injected, like all the contrast, and the radiologist is happy with it, they will tilt the table down. So if we're trying to see their L spine or their T spine or their C spine, your contrast is starting at the base of your spine. So we're going to have to tilt the table where their feet are up and their head is a little bit further down. And we're going to give it a few minutes to allow the contrast to highlight and fall down basically in the spinal canal. And so then before we take them off to CT to see better images, because X-ray is very limited, oftentimes we're going to try and get them onto our stretcher and we're going to have them roll a few times. So we're going to say, try and roll on your back to your belly, to your back to your belly a couple times. And that's just going to help coat the entire inside of the spinal canal. So anterior to posterior, left and right. So that's something that's a little bit different, obviously, that we have to do it in X-ray to start. That saves time in CT. So if we have other emergent situations or patients, we can continue with that. X-ray usually is able to kind of compensate a little bit more for an exam like this, but their typical imaging is not enough for a full study, I guess you could say, to ensure that they don't have some type of stenosis or mass of some sort. So you can see that over here, the whole entire spinal canal is filled with contrast. It is not unusual for the base of the spine to have more contrast, kind of um, it's very potent down there, so it's very bright because that's where it was injected to begin with. And this patient actually has a mass within their spinal canal, and therefore it's pressing on the spinal cord. I would expect this patient to be feeling a lot of radiculopathy, possibly low back pain with that as well, but definitely probably having some issues, probably in their legs. Could affect one side more than the other. Nerves are just very interesting to me. You can affect one side of your body, but not affect the other side. It may only come in more like hot or cold instances. But nerve pain is so different than other pain. Um, it's almost like when the patients are telling you, I'm having this type of pain, you're like, oh, well, that has to be nerve related because it doesn't sound like you got a knot in your muscles. It's just different. So myelograms are a possibility that you could be doing out in the field.